We're going to discuss the practical management strategies of COVID-19. And to understand the strategy, we have to understand the trinity of COVID-19. It has three important parts. One is the infection, followed by inflammation, and then the immune response. To understand the infection, in the coronavirus family, there are 4 human coronaviruses which cause the upper respiratory tract infection or common cold. And there are only 3 of them which descend lower into the lower respiratory tract and cause pneumonia. So the 4 coronavirus family members are 2 alpha and 2 beta. And these 4 cause common cold, which has been very commonly seen in the children and young adults. And 2 of these beta coronaviruses in this family have cross-reactivity with COVID-19. There is a cross-reactivity between the viral spike glycoprotein. And this cross-reactivity can account for almost 10 to 20% in the young population, and that may be protecting them from COVID-19. So the 3 lower respiratory tract viruses, as we know of, are MERS, SARS, and COVID-19. The horseshoe bat has been the reservoir for coronaviruses for centuries. And in 2002, it jumped into civet and then into human beings and caused SARS-CoV-1. And in 2012, it caused the Middle Eastern Respiratory Syndrome. And now in 2019, it caused COVID-19. So these 3 viruses have a lot of similarities and also some differences. In SARS 2002, there were 8,096 patients, 774 died, and it went to 29 countries with a case fatality rate of 11%. In MERS, it was predominantly in Saudi Arabia, where there were 2,494 cases, 858 died, and went to 27 countries with a case fatality rate of 35.5%. And now in COVID-19, almost 172 million people have been affected and 3.7 million have passed away. Has affected 213 countries with a case fatality rate of only 2.4%. The commonality is that in SARS and SARS-CoV-2, the entry into the cell is through the ACE2 receptor, whereas in MERS, it is through a different receptor called DDRM. How is the coronavirus transmitted? From human to human, there's a transmission from small droplets, which can range from 5 to 50 micrometer, or large droplets, which is aerosol transmission. It can be also from direct contact and also from contaminated surfaces if you touch the surface and then touch your face. There can be accidental exposure in the lab, and that is why there is high security wherever there is coronavirus being tested. There can be cases of blood transfusion transmission or even organ transplantation, but none of that has been recorded as yet. A couple cases have been recorded of possible transplanted placental or vertical transmission to the baby or the fetus. The way you diagnose is that there is an incubation period of about 5 to 7 days before the virus infects and causes symptoms. So it's -1 week is the incubation period. And thereafter, the first symptom will appear somewhere here. And that's when the PCR will become likely positive. And thereafter, the viral load will gradually go down in about 10 days or so. And this is a high infectious period. And that is when you can do the antigen test, even though it is less sensitive, but it is very sensitive for high viral load. The PCR likely become positive in this duration and can go up to like 3 to 4 weeks. Thereafter, the PCR should become negative. And if it is still positive, it could be false positive because it is a very mild viral load at that time. And that you can determine by doing the CT value from the PCR test. The CT value tells you about the viral load. If it is less than 24, it is extremely high viral load. And this is the most contagious and the infectious period in coronavirus. The CT value ranges from 25 to 30, which is during the infectious period or the symptomatic period, and then more than 35 CT value is false positive. We usually don't check IgM or IgG antibodies for diagnosis. So the symptoms, as we all know, the most common is fever, fatigue, chills, headache, nausea, nasal congestion, and most importantly, when people have loss of smell, in about 86%, these people usually get mild COVID. They do not get severe COVID. So it's very important. If a person has loss of taste or loss of smell, they most likely will get mild COVID. Almost 15% to 20% can get diarrhea and not get any respiratory symptoms. There are some high-risk groups, as we know, people with health issues like chronic obstructive pulmonary disease, hypertension, diabetes, heart disease, kidney failure, people in the ages of 60s or 70s, and of course, weak immune system, patients who are immunocompromised from immunosuppressive therapy, organ transplantation, or having other immune problems like autoimmune disorders. And then obesity or overweight people have increased ACE2 expression, and that is the reason that they are very high risk for getting COVID-19. This is the coronavirus structure, which shows you there are 4 different proteins in the virus. This is the spike protein called the glycoprotein spike S. Then there is a membrane protein M. There is a nucleocapsid protein N, which covers the RNA within, and there is an envelope protein E. It's important to understand these different proteins in the coronavirus because they have different significance. With the N protein, when the natural infection occurs, 70% of the antibodies are created against the nucleoside protein, and 30% antibodies are generated for the S protein. The S protein is the most important protein in the virus because this is how it makes the entry into the human cell. This is the structure of the S protein, and it has a portion called the receptor binding domain, or RBD. And this is very important, and this is the area of interest when we create a vaccine to create the neutralizing antibodies for the RBD. This is the subunit 1, and this is the subunit 2 of the spike protein. There is a stalk and there is a head. And these are the 2 different parts, the S1 and S2 of the spike protein. When you get the antibodies, we are focusing on the S protein neutralizing antibodies and not as much on the nucleocapsid protein antibodies in the vaccine. This is how coronavirus enters the human cell. As you can see, this is the spike protein. And in the host cell, there is a transmembrane serine protease 2. And this activates the spike protein. It cleaves the S1, S2 subunit, and it activates the receptor binding domain of the spike protein. And that is how it attaches to the angiotensin converting enzyme ACE2 and gains entry into the human cell. Once it enters the cell, and ACE2 or DPP4, this is for MERS. So SARS-1 and SARS-2 enter through ACE2 with the activation from the protease. They will enter the cell, and then the RNA is released within the cell, and there is multiple copies are made, and this is called replication of the virus within the cell. And then again, the virus particles are organized with a capsule, and they are discharged to infect other cells. This process of replication goes on, and they make hundreds and millions of copies inside the cell. And this is where if something goes wrong, it's called mutation. And because of the mutation, that's how a variant is born. So every time there is replication, there is going to be mutation. So far, coronavirus has mutated more than 100,000 times. And every month, one or two important variants arise from that mutation, which become the dominant. So sometimes it is the UK variant which is dominant, some now it is Indian variant which has become dominant, but it has nothing specific to the country. It is a pandemic. Pandemic means it's all over the world. It is just the endemic area where the variant starts and then spreads all over the world. Already the variant has spread to many other countries, which they call Indian variant, which is not the right thing to do. One has to call them as alpha, beta, gamma, delta, epsilon, zeta, eta, theta, iota, and kappa, because it gives a stigma to a particular country that the variant arises from there. It has nothing to do with any particular country. These variants are born as long as there is pandemic and as long as the entire world is affected. This Indian variant, that's the so-called Indian variant, was Delta in October 2020, and now it is Kappa and the most recent one is the B16172. And this came in May 2021. And this variant has already spread to other 20 countries. So as you can see that this is the virus spike protein, and these are the mutations occurring in the receptor binding domain of the different, and the very different variants are formed. So when the variant is formed, there's a consequential effect of increased transmissibility, increased infectivity, possible reinfections, and the COVID vaccine match and effectiveness is decreased. And again, also it affects the COVID therapeutics. So when this variant spread very fast, it will cause more infection. But again, the more the transmissible the virus, the less virulent it is usually, because if it is a very virulent variant, it is going to kill the host, and the spread will be less because the host will also die with the virus. The ACE2 expression occurs in the human body in these different areas, and you'll be surprised that the maximum ACE2 is in the kidneys, in the small intestines, and the testes. The erectile dysfunction is extremely common after COVID-19 infection. So this is the message to all the world, that if you do not get the vaccine and you get the natural infection, you may not be able to reproduce. And ACE2 receptor is also in the lungs and the heart, but not with the same extent as the small intestine. And this may become a reservoir for virus shedding, because many people may continue to shed the virus in the stool even after the COVID-19 is gone. The ACE2 expression causes the different symptoms and different involvements in different areas. In the heart, it causes, as you can see, involvement of the cardiomyocytes. It can cause myocardial infarction, it can cause myocarditis, it can cause heart failure, it can cause acute kidney failure, it can cause, of course, pneumonia, we'll discuss. It affects the endothelial cells, which is very important. The endothelial lining of the vasculature is almost 4,000 miles inside the human body. And imagine if these cells are affected, the entire vasculature is affected by coronavirus. It affects the central nervous system, but there are no ACE receptors in the brain. Most of the problems occur because of inflammation of the brain by crossing the blood-brain barrier with the cytokines, and also because of the vascular inflammation. You have to understand that the way the coronavirus causes the damage is through oxidative stress. And once the ACE2 enzyme is affected, the angiotensin II is not converted to the friendly angiotensin 1,7. And instead, there is more accumulation of angiotensin II, which causes formation of reactive oxygen species. And this oxygen, which is being converted to water, becomes superoxide. And their hydroxy ions and hydrogen peroxide are making the reactive oxygen species, which causes cellular damage, and that's called oxidative stress. So one, because of the conversion of lack of conversion of angiotensin II to angiotensin 1 and 7, and the other will be that with the infection of the SARS-CoV-2, there is increased infiltration of the neutrophils, which also causes oxidative stress. Besides the aging and comorbidities, hypertension, coronary artery disease, diabetes, obesity, there is increased oxidative stress. And that is the reason they get more severe disease than the young people. So when there is a normal cell which is affected by the free radicals, they damage all the components of the cell, and that causes the cell death, apoptosis, or necrosis. So once there is increased reactive oxygen species accumulation, it will cause the impaired RBC quality, and this will lead to platelet aggregation and thrombus formation. And this thrombus formation is because of the coagulation factor, especially the von Willebrand factor, which is released from the endothelial cells. So when the ACE2 is decreased, the angiotensin II is increased, and decrease in angiotensin 1 and 7, it can cause so many problems in all the organs. It decreases the insulin sensitivity and increases glucose uptake. It decreases the insulin sensitivity and fibrosis in the liver. It will cause hypertrophy and inflammation in the kidney. Same in the skeletal muscles, the insulin sensitivity is decreased or insulin resistance is increased. In the lungs, it will cause endothelial dysfunction. Brain will activate microglial, elevated cytokines will cause neuroinflammation. Same in the pancreas. And in heart, it will cause inflammation and increase altered conductance or cardiac arrhythmias. In the vasculature, there a decrease in the nitrous oxide production and worsening of the endothelial dysfunction, all related to this mechanism of renin-angiotensin. So the extrapulmonary manifestations of COVID-19 can be in multi-organs. It can cause skin problems, endocrine problems of hyperglycemia, diabetic ketoacidosis. There's a bidirectional relationship between COVID-19 and diabetes. It can cause new diabetes, and type 2 diabetes can become type 1 diabetes, and it can cause very uncontrollable hyperglycemia. It can cause cardiac injury with cardiac arrhythmias, cardiogenic shock, myocardial ischemia. Thromboembolism, extremely important because it increases the chances of deep venous thrombosis and pulmonary embolism. Even catheter-related thrombosis occurring because of the coagulopathy, which is an extrapulmonary manifestation of COVID-19. It can cause acute kidney injury with proteinuria and increased potassium excretion in the urine and hematuria. And besides that, the neurologic symptoms are more related to the inflammation and the vascular involvement. So we discussed the infection part of the Trinity, and let us understand what is the inflammation part. So let us say somebody calls you and says, I'm COVID positive, what are you going to do? What I tell my patients that we have to observe three different things: cough, fever, and shortness of breath. And most importantly, I would like to monitor fever and oxygen saturation. These are the two parameters which will guide me the practical management of COVID-19. While some poor people cannot afford this, so they can rely on shortness of breath as a substitute for the pulse oximeter. So most importantly, what happens is that normally we have normal saturation, which is anywhere between 90 to 99% on room air, and below 90% is hypoxia. But in COVID-19, something happens which is misunderstood, that anytime the saturation goes below 94% to 90%, the person may not experience hypoxia, and yet they may be hypoxic, because there is a disconnect between the arterial oxygenation and the oxygen saturation measured by the finger. And the reason for that is that COVID-19 affects the ACE2 receptors in the peripheral chemosensors and chemoreceptors, and they block the afferent mechanism going to the respiratory center to affect any shortness of breath or dyspnea. And this can be affected because of the afferent relay to the respiratory center, and also the efferent response is also blocked because of the ACE receptor. There is also a shift of the oxygen dissociation curve to the left, so the oxygen binds to the hemoglobin much more than it would otherwise, and will be causing the arterial hypoxemia and not showing on the oxygen, showing on the oxygen saturation, but not showing on the arterial hypoxia. This is called the silent or happy hypoxia, that the respiratory mechanics remain preserved, and yet the patient is having low oxygen inside the body, whereas the oxygen saturation is between 90 and 94. And this I call as the yellow zone. So this is the time when the person is having inflammation. That is how you define that the infection has become inflammation, when the saturation is changed between 90 and 94%. Or clinically, the patient is short of breath. So what is the course of the disease? When there is infection, 80% of the population will have immune success and will have a mild disease or asymptomatic or very minimal disease. The 20% will get moderate disease, and these people, 5% of these will go into the ICU, and 40% of the ones which go to ICU will die. So this is a very important thing, that if we can treat these people and not let them go here, and these people not let them go here, then we can have a good strategy of treatment. This 80% immune success, it depends on your immune system. What happens is, once there is infection, the body immune system comes into play. And there are two immune systems, the innate immune system and the adaptive immune system. The innate immune system comes into play within 2 hours after the infection. And this may take about a week or two to come into play. And the most important cells of the innate immune systems are the natural killer cells and the monocytes. And these two cells, they liberate a thing called interferon. Interferon means it interferes with the viral infection, interferon. And what SARS-CoV-2 does, it destroys the interferon. And that is how it beats the immune system. So there is a tug of war between the interferon production and the interferon resistance from the COVID-19 or SARS-CoV-2. And this is extremely important to understand, that initially, when there is a type 1 interferon response from the NK cells and there's a viral load, the innate immune response is the one which protects you, and it is this which is active in these 80% people who get mild disease and do not suffer. And once this fails, then you're going to get into the 20%, and that will be responsible for the adaptive immune response, which will not be active enough, and we may not have good enough resistance, except in the young people, like I mentioned to you, and young adults who have 20% cross-reactivity with the spike protein, and their antibodies may be able to help, and they may not proceed from here to here. This is an article from Science magazine. What they showed, that the interferon activity and inflammatory responses in severe COVID-19 patients. If you see the interferon response in mild patients is extremely high, and as you get into severe illness and critical illness, the interferon response goes down. And the activity again here is mild is high and severe and critical. this is very interesting paper from Science magazine, that it is the responsibility of the interferon to contain the disease. If the interferon doesn't respond well, then it becomes severe disease. And they have seen that patients who do not have any interferon response are the ones who have antibodies to the interferon in their body, and they will not mount a response for the interferon, and they'll get severe disease. And there are also young patients who get sometimes severe COVID. And the reason for that is that these people have mutations in the gene which produces the interferon. So if patients have mutations in the interferon gene, or they have antibodies to the interferon, they're going to have severe disease. Whereas people who have no antibodies will have mild disease. Also, interferon is 10-fold more when there is body temperature. When the core body temperature increases, the interferon production increases, you see. This has been seen by doing lab work, by inducing mitogen stimulation to see the interferon response in high temperature. So now we are having fever and we are trying to suppress the interferon response. I get called all the time, patient has 102 fever, 103 fever. Can I give NSAID? No, I have never seen anybody die of fever. Why are you destroying the natural response which is going to protect and make it a mild disease? Interferon is the answer. And even they're thinking of giving interferon for viral infection so that it can interfere with the viral replication and viral growth. So temperature, I do not treat. I would like not to treat up to 103. I've never seen anybody die until their temperature is 105. They're pushing for their temperature control, and they're destroying this interferon response, which is controlling the disease. So early interferon response, when it is adequate, it is going to cause rapid viral clearance and mild disease in the young and the low viral exposure, you see. And then if it is a delayed interferon response, like you see here, there'll be increased viral load and there will be severe disease in older adults and high viral exposure. And if there is low or no interferon response, there'll be no viral control, inflammation, and there'll be severe disease. And this is because of the genetic mutations in the IFN pathways. And there is neutralizing antibodies of the interferon, like I explained to you. And that is why we are talking about injection of recombinant interferon to decrease and the viral load and make it a milder disease. This may be the early treatment for recombinant interferon. So once the ACE2 receptor has been affected, it will cause the angiotensin 2 activation and the complement activation and reduce angiotensin 1,7. This is our friend. And this is what is reduced, and this is our enemy, which is increased. And this will lead to hypercoagulability state and microangiopathy. And then, of course, the cytokine storm and the tubular damage in the kidneys, rhabdomyolysis, and hypoxia and hypotension. So what's happening inside the lung? When the virus comes in, it will affect the alveolar type 2 cells. The alveolar type 2 cells make surfactant. And the surfactant is responsible for the surface tension of the alveolus. And once the surfactant production is gone, there will be a collapse of the alveolus. And because of that, there will be shunting, because this alveolus will collapse, and yet there will be blood flow. So the oxygen will not be picked up because there is no alveolar air, whereas the circulation is still going on. And this disconnect is called ventilation perfusion match. So as you can see that with the SARS-CoV-2 coming in, there is destruction of the alveolar type 2 cell. And then there is release of the cytokines because all the macrophages and the neutrophils come inside the alveoli. There's a lot of lymphocytic infiltration. And this is lymphocytic infiltration is the sequestration in the lung, which is causing the lymphopenia when you do the blood test. And then the endothelial cells will get affected, and there will be a leak. There will be a capillary leak. And this basement of the endothelial cells will liberate the von Willebrand factor and the platelet aggregation and then clotting formation in the small capillaries in the lung. And there is the fibrin which is produced because of the clotting mechanism. And when the degradation products come out, that is called the D-dimer, which is indicating to you that there is thrombosis going on within the small capillaries or microthrombus. So when you look at the microscopic structure of the alveolus, you will find that there is a lymphocytic infiltration. And this is a capillary which is open, whereas this is microthrombosis occurring within the capillary. And this is the alveolar space, and this is all fibrin inside the lung. So as you can see, there's a subendothelial release of von Willebrand factor 7, and this will cause thrombosis and angiogenesis. And there'll be pulmonary vascular endothelialitis, or the inflammation of the endothelial cells. This is the gross appearance of the lung, and this is the lymphocytic pneumonia which people get. Tremendous lymphocytic infiltration in the lung. And this is the electron microscopy of the lung in COVID-19, which is showing there's an interceptive angiogenesis, vascular formation. And then there is a virus which has been localized in the endothelial cell of the lung. So there's diffuse alveolar damage. There's microthrombi in the small pulmonary arterioles, microthrombi in the small pulmonary arterioles, you can see here and here. And there is all inflammation in the alveolar epithelium involving the alveolar type 2 cells as well as type 1. So in a normal lung, when the lung surfactant is produced by the alveolar cells and the destruction and the activation and the cytokine secretion is controlled, this will be a normal phenomenon. Normally, the cytokine secretion is beneficial. This is how you control the inflammation. However, when it exceeds, when the fire is out of the fireplace, that is called the cytokine storm. There is massive macrophage infiltration, alveolar macrophage activation, and the excessive release of the cytokines is going to cause cell damage. Little release is beneficial, but excessive release is the dysregulation or the release of excessive cytokines causing the storm, destruction of the type 2 cells, and severe loss of anti-inflammatory lung protective surfactant. There are two different kinds of lung involvement which one must understand with the treatment strategy. There is L phenotype and H phenotype of lung involvement. In the early stages, there is low elastance, high compliance, low VQ, low lung weight, low recruitability, and ground glass appearance, which we already see so many times in high definition CT scan. This is thromboinflammation. There is thrombosis going on and there is inflammation. And this is interstitial edema, which is happening in the L phenotype. The compliance is normal for the lung. And initially when the COVID-19 came, everybody was putting them on ventilator. And these are the patients who should not have been put on the ventilator. And that is why there was increased mortality with ventilation. And this study came out from Italy when there was Dr. Gattinoni, he is one of the famous pulmonologists. He did autopsies on these patients who passed away from COVID-19. And he found out there were two different phenotypes. One was the phenotype L, which this is more predominantly thromboinflammation, where there is microthrombosis and inflammation and interstitial edema, which is usually peripheral and localized. And by the way, there is no pleural effusion in COVID-19. So if you see a CT scan with pleural effusion, you should make some other diagnosis as well. Here, the lung weight is low because there is not much of fluid and there is a ground glass opacity. Whereas in the H phenotype, when the disease becomes severe, there is high elastance and low compliance with high ventilation perfusion, high lung weight, high recruitability, and that's when you require the PEEP, because now you're going to recruit the alveoli. You cannot recruit the alveoli here because these can be recruited when you give the positive end expiratory pressure. And this is the classic ARDS, and this is atypical. So this distinction has to be made when you're treating the patient. This will occur most of the time between 90 and 94%, and this is below 90% oxygenation. So let us understand that when there is a symptom onset, the oxygen saturation remains normal, and this normal is up to 95%. And this is mild disease. This is when you're having fever, viral replication. This is when the interferon is coming out. And now we are treating them with all steroids and controlling the temperature and then letting them go, come on in here. That has become more severe. No, I do not start the treatment until they become in the yellow zone. So the grand glass appearance will occur here, interpulmonary shunting will appear with edema and atelectasis with ventilation perfusion mismatch, intravascular microthrombi because of 1 billion factor and 11. And this is the L phenotype with the yellow zone where there is loss of lung perfusion regulation. And the reason is that usually when there is hypoxia, there is vasoconstriction, but there is failure of that. Instead, the lung is collapsed and yet the blood is flowing, and the hypoxia is not causing the vasoconstriction, there is vasodilatation. And the vasodilatation is occurring because of the ACE2 is not able to convert to A17, and instant there is more bradykinin production. And people talk about the cytokine storm, I talk about the bradykinin storm. And the bradykinin is causing this hypoxic vasodilatation here and causing more shunting when the alveoli are collapsed. Then once the saturation goes below 90%, now you're getting into the severe disease. And this is the H phenotype, where there is reduced lung compliance, increased dead space, increased consolidation and atelectasis, and there is CO2 retention. And this is when the dyspnea starts. Dyspnea usually starts when the arterial oxygenation is about 40. And this one is, that is the reason from here to here, the person does not have dyspnea. Person is not short of breath. That is why they are called happy hypoxic. That is why it is called silent hypoxia. So one has to be very careful of this yellow zone. And this is what you have to treat, which is the moderate disease. This is the mild disease, this is the moderate disease, and this is the severe disease. So that's why you have to use the antiviral here and reduce the immunosuppression, anti-inflammatory medications, and prone ventilation, anticoagulation, and all these will depend, and the oxygen therapy will switch into mechanical ventilation as we progress from the L phenotype to the H phenotype. The third aspect is the immune response. So when there is a mild to moderate COVID-19, there is an efficient production of interferon 1 and activity, and there's viral clearance, and there is a regulated inflammation. So there are cytokine release, which is mild to moderate pneumonia and resolution of the disease. But once this regulation becomes a dysregulation, there is impaired interferon response because of the genetic or the antibody, as I explained earlier. There may be other host factors because of other comorbidities. There is viral persistence and the viral cannot be controlled. And this is what causes the cytokine storm and the exacerbated inflammation and the tissue damage. And there is autoamplification loop and then the multi-organ failure and ARDS because of chemotaxis of a lot of neutrophils and monocytes coming to the site and liberating the cytokines. So when there is COVID infection in the epithelial cell, there is reactive oxygen species, like I explained to you, there's oxidative stress and the cell death. And because of that, there's immune evasion from the activated T cells, macrophages, neutrophils, and these are the ones which release the cytokines. IL-1, IL-2, IL-6, TNF-alpha. IL-6 is the most important, and that is what we measure. And this will lead to, as you can see, the lung damage, the GI, brain, cardiovascular, liver, kidneys, and of course the microcirculation causing the hypoxemia. So when the SARS-2 co-infection overwhelms the immune system, there will be cytokine storm, release of other cytokines from the monocytes and the other C cells, There'll be pneumonia, there'll be hypercoagulability, there'll be epithelial damage with the microthrombi, rhabdomyolysis, microembolism, kidney infarction, and there will be hypervolemia because of the renal affection, myocardial dysfunction, and that's when you get ARDS and you require mechanical ventilation or ECMO. And there is endothelial dysfunction. So this is the pathophysiology of the severe disease which can help prevent. So the macrophages, dendritic cells, T cells, fibroblasts, endothelial cells, they will release all these cytokines. And these are the different cytokines which cause different problems: fever, impaired hematopoietic function, DIC, decreased serum protein. This is very important. The albumin half-life is only 21 days. And most of these patients have hypoalbuminemia because of poor nutrition, and they get severe disease, and they're never checked. And they're given fluids in ICU, and they will increase the interstitial fluid and will make it worse. The ARDS will get worse because if you do not treat this protein, there'll be decreased oncotic pressure and there'll be increased fluid retention in the lung. The interstitial space of the lungs can contain 2000 cc's of fluid before it shows on the CT scan. So this is a hidden problem which is being overlooked. Then of course it will cause hypercholesterolemia, has been seen with COVID-19, and acute kidney damage. Anemia happens because the SARS-2 will cause disintegration of the heme from the globin and release the iron ion. And that is the iron ion which is released and which will be captured by the ferritin. And that is why the ferritin is increased in coronavirus 2 infection. We always measure the neutrophil response with the lymphocytes. And as you can see, the neutrophil lymphocyte response is usually 1 to 3. And there is increased lymphopenia because the lymphocytes are being sequestered in the lung. And the neutrophils are increased because of the infection. And there is an increase in the NLR stressometer. And this will also increase if you give too much steroids, because the steroids will increase neutrophils and also decrease the lymphocytes. So one has to be very careful interpreting these results, especially when the patient is on steroids. These are the different lab work that we do. The CRP is liberated from the liver, and it goes up in any inflammation or any infection. However, in this case, these are the numbers which tells you mild, moderate to severe. If it is more than 100, and the IL-6 is more than 100, that's when we talk about the cytokine storm. So these are the thresholds for CRP and IL-6. The D dimer is usually less than 0.5. However, when it is more than twice the normal value, or it is more than 1, that's when you have thrombosis. That's when you have microthrombosis, and that's what requires anticoagulation. This is extremely important. And D dimer persistence, even after COVID-19 is gone, which means that there will be increased pulmonary fibrosis, and there will be long COVID. So D dimer can be an indication of long COVID if it is persistently high. And if more than 1, of course, is moderate to severe. This coagulopathy is a major thing which has to be treated besides other things. The NLR ratio, as I discussed, the ferritin goes up because of the iron release. The LDH means the tissue damage, and ESR means inflammation, which is non-specific. So how do we intervene now that we have understood the infection, inflammation, and the immune response? So the most important thing that we can intervene in the viral phase or the early phase in the non-hospitalized patient is by blocking the SARS-CoV-2 by using monoclonal antibody. Now, monoclonal antibody, as you can see, it is a neutralizing antibody. It will not allow the spike protein to enter the ACE2 receptor in the human cell. So it blocks the entry of the SARS-CoV-2 virus in the early stages. And this can be given to a lot of people, anybody above 65 years old, anybody 55 with heart disease, hypertension, or lung disease, and even more than 18 years old with diabetes or kidney disease, and most importantly, BMI more than 35, or if they are on immunosuppressive drugs. Presently, there are 2 different companies making the monoclonal antibodies, and they are giving a cocktail, they're giving two antibodies. This is Regeneron and this is Eli Lilly. The reason for that is they're trying to attack the receptor binding domain at two different angles. So this way they can hopefully prevent the variants to get inside this human cell. So usually they were giving only one initially. Now Eli Lilly has added another monoclonal antibody. So they're using a combination of two antibodies to prevent and making like a more like a broad spectrum to prevent the entry of the variants. So this is the management strategy. When the saturation is above 95%, the patient may be symptomatic with fever or cough. Do not give steroids and do not try to suppress the temperature, because you are disallowing the human body to respond to the mild disease and control the inflammation. It is only when the saturation goes below 94%, that is when I start that treatment. Not here, only here. This is your threshold for starting the treatment for inflammation. You start with the steroid, anticoagulant, maybe oxygen and prone position and remdesivir we'll discuss. And then, of course, when the saturation goes below 90%, this is the time for going into ICU. This may be the time for hospitalization. This is for ICU, but this is at home. So this is decided about the green zone, the yellow zone, and the red zone. People start this treatment here. So they are making the green zone into yellow zone. And this is the fallacy of the management. So when there's viral replication, there is fever, there's malaise, there's cough, there's headache, there's diarrhea. Basically, you give antiviral treatment, which is monoclonal antibody, and maybe aspirin for thrombosis. This is questionable. The other thing you can do is when the patient goes into shortness of breath with mild hypoxia, we can start the steroids, anticoagulant, melatonin, remdesivir, or this treatment is indicated only when there is immune dysregulation or the cytokine storm. The corticosteroid they're using is methylprednisolone, which is 4 milligram equivalent to 0.75 milligram of dexamethasone. The dexamethasone half-life is 36 to 54 hours. Methylprednisolone is only 18 to 36 hours. The important thing about dexamethasone is it does not have mineralocorticoid activity or salt retaining potency. So when there is less salt retention, there is less lung edema. When you give this, there is increased lung edema or interstitial edema. So one thing we have to be very careful by using methylprednisolone instead of dexamethasone. The recovery trial which was done was based on dexamethasone. And however, you can use methylprednisolone, there is no problem, as long as you're very aware of the low albumin and you're very aware of the fluid retention from methylprednisolone. That is why it is given twice a day, and this is given once a day, although it can be increased to twice a day in severe cases. So the COVID-19 disease course, as I alluded earlier, the fever, myalgia, insomnia, agusia, dry cough, diarrhea, and headache, if they have anosmia, it is going to be a mild disease most likely. And this is causing the lymphopenia, which is the classic sign here in the viral replication. And this is, you give remdesivir maybe, but usually it's not effective unless there is hypoxia. Convalescent plasma is totally out. This double-blind study has shown it is not effective. It is as good as placebo. What we have to do is use monoclonal antibodies. Now, remdesivir, when they tried without hypoxia, is not as effective in reducing the hospital stay. It decreases the hospital stay only when there is hypoxia. And it can also be combined with dexamethasone. And this is the stage of shortness of breath, hypoxemia, and bilateral chest infiltrates. And their liver enzymes go up, and the CRP, the LDH, the IL-6, the D-dimer, and the ferritin markers, they all increase during the inflammatory phase. And in the severe, you always have to make sure there's no pulmonary embolism because there's hypercoagulability, which may be making the respiratory insufficiency worse and making refractory hypoxemia. It could be myocarditis or even shock. And this is because severe D-dimer elevation and multi-organ failure with elevated troponin and creatinine and lactate. We have to check troponin in all the cardiac patients, even otherwise in elderly who are demonstrating any severe inflammation, because the inflammatory cytokines, they cause cardiocyte damage. And troponin is a very good marker of any cardiocyte damage. So troponin has to be monitored, D-dimer has to be monitored, because they can get myocarditis, myocardial infarction because of thrombosis, and heart failure. So we also have to do a BNP level to make sure that the heart is not the culprit besides the lung in the respiratory insufficiency, because the cardiac failure and the pulmonary embolism, if they are overlooked and you keep treating for ARDS, you're going to miss the boat, because there are other things which are happening besides ARDS, which is overshadowing the underlying problem, which may be myocarditis, myocardial infarction, pulmonary embolism. So I have been using melatonin, being a sleep physician, for sleep. But I find that melatonin is very effective as an antioxidant. If you remember, I told you there is oxidative stress when the coronavirus infects, and this causes release of reactive oxygen species. And melatonin is very effective in blocking the reactive oxygen species as an antioxidant. It promotes sleep in a patient with COVID-19 who has moderate to severe disease, because I call it COVID-somnia. COVID-somnia will cause more anxiety and more difficulty with the sleep. And melatonin also helps in the delirium which is produced by COVID-19. And it has been very effectively used in myocarditis in Coxsackie B. Melatonin has been very beneficial to even prevent myocarditis. It causes immune modulation by decreasing the cytokine release, as you can see here. So I've been using melatonin very effectively in these patients. Second thing I use is vitamin D. They saw that anybody who was vitamin D deficient had a very high mortality. Vitamin D deficiency has to be treated, and vitamin D level has to be checked. And any patient, at least the one going to ICU, because vitamin D deficiency will cause lack of antioxidant, lack of immunomodulation, increased cytokine production. And there's a study going on that even a patient going into ICU, if the vitamin D level is low, they're giving 50,000 units of vitamin D for 5 days. And then after that, they're going to start at like 4,000 units, which is the recommended dose thereafter. Now you will say they'll call it toxicity. A study was done in Mayo Clinic with 20,000 patients given vitamin D, 50,000 units for 5 days. Only 1% had hypercalcemia. So it's pretty safe. You can give vitamin D. Make sure the vitamin D level is above 30. Otherwise, there'll be increased mortality. Vitamin D has been used in ARDS in the past, and it decreases the cytokine production. And most importantly, it decreases the renin-angiotensin system. It prevents the conversion of the angiotensinogen to angiotensin 1, and it prevents the worsening of the angiotensin 2 production and pulmonary vasoconstriction in severe COVID disease. This is a very important function that the vitamin D does. So now that the acute COVID is, let us say, taken care of, after 1 week, 2 weeks, 3 weeks, at the most 4 weeks, the patient is discharged. Now they can land up with subacute COVID or even chronic COVID, where the PCR is negative. The PCR is about 35 and maybe continue to remain positive. That is false positive because there may be degenerate RNA particles, and being PCR a very sensitive test, it may continue to be positive for several months. And this can, as you know, the subacute or the chronic COVID-19 is causing fatigue, decline in quality of life, muscular weakness, joint pain, shortness of breath, cough, persistent oxygen requirement, anxiety, depression, sleep disturbance, PTSD, brain fog, cognitive function decline, headaches, palpitations, chest pain, thromboembolism, pulmonary thromboembolism occurring, chronic kidney disease, and hair loss. The suspected mechanism is autoimmune dysfunction, or there may be persistent viremia because of poor immunity or poor immune response. And in some people who are immunosuppressed, they may have reinfection, they may have relapse. So a lot of research is going on this, and we'll have more answers as research goes on. So the assessment has to be, for example, in lung function, people are developing pulmonary fibrosis, almost 25 to 30%, but these patients are the ones who have severe COVID, who are elderly, and who were on long-term mechanical ventilation. These are the ones who are getting pulmonary fibrosis, not a young man who had only pneumonia and he's not going to get pulmonary fibrosis. And one of the markers for this pulmonary fibrosis is D-dimer. If it is more than 1500, then one should suspect that person may develop pulmonary fibrosis, and antifibrotic therapy may be begun. One has to be very careful that people are developing myocarditis even after COVID. 60% of people who had mild COVID were included, who were found to have MRI positive for myocarditis. And this is because there may be residual inflammation on the heart muscle. And this may be causing symptoms of heart failure, cardiac arrhythmia in people in long COVID. Also, they're saying there is a postural orthostatic or POTS tachycardia, postural orthostatic tachycardia called POTS. And the reason for that is autonomic dysfunction, that the virus affects the sympathetic nervous system, and they get fatigue and tachycardia of 130 or above when they start to exercise or move, and the blood pressure drops because they cannot sustain and maintain the blood pressure. There's orthostasis. So orthostatic hypotension with dysautonomia, then one has to look at the pulmonary function test to see if there is any problem with the diffusion capacity. That is the way you would be able to tell if there is any fibrosis setting, and 6-minute walk test to see how the lung function is improving. Then, of course, you have to treat the PTSD and anxiety, depression, and cognitive impairment, which is a very serious problem in a lot of people because of the persistence of the symptoms. And then you have to give the thromboprophylaxis in the high-risk survivors for maybe 3 months, maybe 6 months. It will all depend on the patient's profile. So thromboprophylaxis is extremely important and may be overlooked some patients, and that can result in myocardial infarction. It can result in stroke post-COVID. So this is a very important aspect in long COVID, which has to be not overlooked. So you see, there have been several pandemics. Pandemic means when the infection is all over the world. Endemic means when it is only in one country. And as you can see, in 1300, 1,200 million people died of Black Plague. And now smallpox killed 56 million people. COVID-19 has killed about 3.7 million people with a 7 billion population. So it is not as bad as previous pandemics have been. However, the problem is that they probably did not have as much travel, and you know, these patients did not have as good management as we have, and that is the reason that the case fatality rate is lower in COVID-19 as compared to other pandemics which have happened. I thank you for your attention.
This webinar brought to you by MeraDoc on COVID-19 Practical Management Series is broken up in two videos. The first one being Dr. Kapoor's, Dr. Raj Kapoor's keynote address, and the second part, which follows, which is a Q&A with two co-chairs, Dr. Kalra and Dr. Tulsi, bringing the Indian experiences and blending it with the global one. So I would request you to access both. We split it in two parts to just make sure that the files are of the right size and easily viewable by the audience.